Hola, bienvenidos a un nuevo capítulo de estas series. Mi nombre es Juan Granada, CEO del CRF con Columbia University en Nueva York. Hoy les traemos una charla muy interesante que es dada por uno de mis colegas, el doctor Susheel Kodali. Él es un experto, como algunos de ustedes lo conocen, en enfermedad estructural. Es un operador de alto volumen en TAVR, en nuestro centro, y también hace mucho MitraClip y también exclusión de la auriculilla izquierda. Él nos va a hablar de sus perspectivas personales acerca de la revolución que ha creado la terapia estructural en nuestro campo. Creo que es muy interesante porque es un recuento histórico, un recuento tecnológico y un recuento clínico del estado actual, las necesidades y los retos que tenemos hacia el futuro. Yo sé que la enfermedad estructural es un campo que apenas está empezando en Latinoamérica. Los centros apenas están adecuando, el concepto del Heart Team apenas se está formando, pero de verdad es muy interesante entender la evolución, el pasado, el presente y las futuras perspectivas en este campo que muy probablemente va a ser un campo que va a dominar el área de la cardiología intervencionista en un futuro. Espero de verdad que lo disfruten y nos vemos en el próximo capítulo.
Okay, everyone, if folks want to take their seat, I think we're going to get started with the morning program. This is the structural heart segment of the day. I'm joined to my left by Susheel Kodali. He's the director of the Structural Heart Valve Center at Columbia. He's going to kick us off with some perspectives on his journey from fellowship through early career in structural heart intervention. You'll then hear a series of talks on all aspects of TAVR, mitral interventions, and some transeptal left atrial appendage work to finish it off. So without further ado, Susheel Kodali.
Great. So thanks, Tamim. So we'll get started here. The goal of my first talk is I've been doing this for the last couple of years. I had the fortune, I was interested in structural. I did finish my fellowship in 2005, and during the era of TAVR, I've been a part of this. Just go through and just give some of my perspectives in regards to this. So actually, I put this picture up. For me, this was a great moment. I came down late yesterday because there was a Heart Valve Society meeting that Marty Leon was the president of the society this year, was in New York. And this year is the 50th anniversary of that circulation article that we've all seen, that graph by Braunwald, where the mortality at 2, 3, and 5 years based on symptoms with aortic stenosis. So they did a commemorative session, and if you can see here, this is Dr. Braunwald sitting here. That's Bob Bono, Marty Leon, Elazar Edelman, and Alain Cribier. So they went, and it was a great session. They're just giving their perspectives on what they did. And Braunwald's paper was really not a paper based on data. I mean, he's the head of the TIMI group, has done everything, but that paper was based on his observations from 12 patients. And what is crazy about that paper is it still stood up. After you looked at data, it actually worked out. And they were talking about it, and they said that's why sometimes it's just an idea. And it's just putting the idea out there. And that was the last thing that he said he did in valvular heart disease. Everything else was coronary. It was just fascinating to hear the icons talk about how they got to that point and what that perspective was. And it was simply just an idea that came up, he said, at CATH conference. And he said he was in CATH conference, and there was a patient they were discussing with severe AS, but he had some very mild symptoms. And he said the surgeon in the conference said, Dr. Braunwald, if I don't operate on this guy, what will happen? And he thought about it, and he didn't have an answer. And so that was the genesis, and several years later he published a seminal paper. So I think it's fascinating to me that that's the trajectory of things, and it's been, I've had that, I've luckily been fortunate to see that evolution in TAVR. And we go through this, and I haven't changed the presentation. I should probably change it in terms of the case history. But this is what the patients that we often see, 88-year-old hypertensive, creatinine of 1. The STS risk score was 6. And he had the question of SAVR or TAVR. In any center that does TAVR, and it's not a question anymore. Where, 4 years ago, it was still a question. It was like, well, what's good for him? What are the results? And very rapidly, it's evolved away to not be a question. And this patient had, obviously severe AS. On CT scan, anatomy was ideal for TAVR. So, we went ahead with a SAPIEN 3 in this 88-year-old gentleman. This case was done asleep. A lot of our cases are done awake now. This is an older case. And got a very nice result, trivial AR. And the patient went home on day 2. And that's really what's changed. And so what we don't see is the patients that were not coming forward for treatment are now coming forward for treatment. If you look at the STS and TVT database, over the last 5 years, the trajectory of TAVR has been dramatic, over 46,000 done last year. But the surgical decline in surgery hasn't been as dramatic, only a very small decrease. So an additional more than 35,000 patients with AS are being treated. Now you can argue what does that mean for the healthcare system, older population, but it's not that there are patients that weren't being treated that are now being treated, which is different. And so there's a lot of ways and things that happened to get us to where we are right now with TAVR. This was our first case. I was in my last month of fellowship in June of 2005. And Alain Cribier came, and if you guys probably don't remember, but the first cases were an antegrade transvenous transeptal case. So you went, because the catheters were large, you went from the vein into the artery, and we didn't know how to size the valve. So we only had one size valve. It was a 23 valve. But you can see there, the patient, we did the case, and the patient had severe AR. And it was just an undersized valve, simply. And we didn't know. We didn't know how to size. We used a transthoracic echo. He died 2 days later from a multi-organ failure from severe AR. This is our second case on June 9th. Again, antegrade transvenous transeptal, as Alain Cribier had done. He was our proctor for the case. You're putting a stiff wire across the mitral valve. And we lacerated the mitral valve. She had severe MR, and she died on the table. I remember both these patients well. The second case was actually one of the first women to get a PhD from Columbia University. And she died on the table. And that afternoon, I remember being in Marty Leon's office when he called Larry Wood, who's in charge of the Transcatheter program at that time. And this was the 7th case done in the U.S. Bill O'Neill had done 5 at Detroit. He basically told him, this is not viable at this point the way it is. If you don't shut the study down, I'm going to shut it down. And because at some point we push the limits, but you have to step back and take a thought, is this realistic? Is this going to work? Are we helping patients? And so you have to be willing to push the limits, and there are going to be some bad steps like this, but you have to understand. And so this trial was stopped 2 days later, so after this case, and it was then redesigned. And this antegrade approach wasn't viable, so it was a retrograde, sort of like a BAV transarterial. Our first case in the Revival 2 study was in February of 2006. The case went great. The patient did well. We did these with surgical cut downs. The sheath was 26 French at the time, and obviously things have evolved. And 7 patients in that study went great. So then a series of things that we saw. Patient number 10 overall, 8 in the Revival 2, had an uncomplicated TAVR, but she had a dense infarct after. And she had dense hemipresis. She died 5 months later. And we learned here that this is our first experience with embolic events, and that they really are impact mortality. This is our slide. And we were talking yesterday about slides. I have been at meetings in China, Japan, India, where this slide is shown, right? We all share slides. I think this slide has been shown more than we would want to show, because it's our complication. But it was a huge femoral iliac tear. And that was the patient after the stroke. So we learned iliac complications, and iliac angio is not adequate, and this is that patient. Severe railroad track of calcium, and we just sort of sheath got stuck on it, and it tore. So we learned that we got to become a CT expert. We got to look at these vasculature, and angio is not enough, and whoever's doing the procedure has to look at these angios and understand what are the limitations. So then one patient went fine, and then the patient after that, so patient 13, we had a hard time crossing the aortic valve, and what you see here is we've basically just unzipped the ascending aorta. This is a rigid, stiff prosthesis, and you see here 2 lumens, right? This was a 92-year-old. We went to the OR, but she died, and they never were even able to close her chest. Taking a 90-year-old who's inoperable and shocked to the OR probably is not a survivable operation. So it learned a lot of the limitations. And so we did 29 retrograde TFs in the Revival 2 study. We had 5 major vascular complications, 3 iliac avulsions, and 2 aortic dissections, both of which died. And this was sort of pushing the limit. We learned, but we also learned that the device worked. And so we continued to move forward, but we realized we needed alternative access and other things. Is that the WhatsApp? Okay, sorry, or is that my phone? And we needed alternative access, we need new generation devices, and all sorts of things. So, we did our first TA procedure in December of 2006, about 10 months after our TF. It was, again, TA was the only alternative access at that point, and you go through a small thoracotomy. And the procedure went fine. Patient was extubated on the day of the procedure, but she just never recovered. And we learned that it was still a surgical procedure. And for these older, sick patients, it's hard to recover. And it was a big issue. We also learned that we need more sizes, and we need to understand how to size this valve. This is a patient that we only used 2D echo, and the annulus measured 25. And we put a 26 valve, thinking it'd be okay. I think this video, I don't have the video, but she again had severe AR, both paravalvular and central. But I don't have the video display, but basically she ended up going to the operating room and they put in a 29 millimeter valve. So again, we learned that a 25 measurement was one dimension. Annulus is not a circular structure. We're measuring off axis, and 2D measurements are not adequate. And you got to use either biplane TEE or multi-slice CT to get on-axis measurements, and preferably to get 3D measurements, right? And so when you're looking at a structure, and this is a example here, it's relatively circular, but we've seen examples of extreme ellipticity, that you need to understand what this annulus and what the aortic valve complex looks like. And that's, again, coming back to whoever's doing the procedure needs to understand what's going on. So, it's important, and this is some of the perspectives with these mitral trials that are starting. The goal of feasibility trials is not to get a perfect result. The goal of a feasibility study is to understand the limitations of a technology, where are you pushing the limits, and to get learning to plan the pivotal trial. And in TAVR, we had that opportunity to at least learn in these feasibility trials, and unfortunately, it had a lot of complications, but we learned some of the issues. And with that, the PARTNER trial, which was the trial that many of you are aware of, started with the randomized between surgery and TAVR. I'm going to skip through some of this, but I'm not going to go through all these, but Tamim's going to talk a lot about these complications. But over the course of our first 100 patients, we had all sorts of complications. We included a coronary, we had to stent to bail out, and we didn't understand why. And John Webb had published in Circulation his first experience a year before that. But I think although we understood that was the leaflet, we didn't really understand screening. It's not simply the coronary height. There's the bulkiness, it's defacement of sinuses, and all sorts of things that we never really took into account, like including the height, the width, and basically you have to understand, is there room in the sinus for the leaflet to sit? But it all makes sense now. It seems intuitive, and you're like, that was stupid, why didn't we think of that? But at the time, this was all different, and we didn't understand. We were sort of just trying to get the valve in place. And so I think these are some of the things that come with early experience. And understanding now that you have to define the anatomy of the entire landing zone. And I think that's, again, I emphasize to all of you that are interested in structural, if you're going to do it, learn what's going on, not the procedure, but the screening, what are the complications, and even now, all of us review our own cases. Once when we see them in clinic, we look at the anatomy, and in the morning of the procedure, we review all of the anatomy, because that is the key. Pushing the catheter and doing the procedure is the easy part. But then over the time, the devices have iterated as well. That dissection occurred because we couldn't cross the aortic valve. And so and there was no nose cone. It was basically a blunt end of a stent trying to push through a commissure of a calcified aortic valve. And that's what led to these dissections. So they had a Retroflex 2 catheter that came out, but it was short-lived. This nose cone pushed out too far into the LV. And it was actually our fellow in the room that pointed out when this patient was going south, what happened? Notice that there's a double density. We created an LV perforation, and patient ended up going to the OR. Patient 92, we're still within 100. Notice the importance of pacemaker capture. We're deploying the valve, and then we lost capture and the valve embolized. Again, small things early on make a difference, and I think that we've learned that. And then, obviously, new devices have continued to iterate over time. This is the current delivery system with a nose cone that's short. This is the SAPIEN XT, which was first introduced in the PARTNER True trial in 2011. But the first commercial U.S. implant was in November of 2011. So, in the past, you used to say this is a field in its infancy. Maybe it's a toddler or adolescent now, but it's moved on, but it's still early. I mean, the first human case was Alain Cribier in 2002. The first commercial implant in the U.S. was 2011. So, less than 7 years ago. So they're still iterating. There's people gaining experience in different centers. But the key thing is, with the approval, we were able to start thinking outside the box and seeing the real true advantage. We did our first valve-in-valve for bioprosthetic AS a month after approval. We did our first double valve aortic and mitral through a TA approach at the same time. And we did our first tricuspid valve the following year. And these were patients that didn't really have reoperative options. And in this technology, we started to really understand the power and how it really improved. And so from 2005, from our first case to 2012, we did 500 cases. We do close to 500 cases a year now. So there's a rapid evolution over time. And I think that growth and that learning curve was important for us. I'm going to skip through some of this, but right now the currently approved devices are the SAPIEN 3 and the Medtronic Evolut R and Evolut Pro. And these device iterations have been important. They've made the procedure safer. They've expanded the patient population we can treat, and they've rolled out relatively quickly if you think about it. And, in a 7-year period, multiple iterations of next generation devices. I'm not going to go through a lot of TAVR. Tamim's going to go through the data and everything else. But the PARTNER trial, we've published, I don't know how many manuscripts from it. I've been fortunate to be involved in it. My colleagues Tamim and Torsten have. But the key thing is, it was a trial from 2007. And the reason I mention is I still hear people quoting data from it, the stroke rates from the trial and everything else. This is a first-generation device that is not reflective of outcomes now. And I think that's important to keep in mind. When this trial started in 2007, less than 100 TAVRs have been done in the US. And so very little experience, limited centers, and everything else. So really does not represent contemporary results. If people are talking about data, you can't really focus on that. And as I said, the devices have iterated. And intermediate risk, again, showed non-inferiority, and Tamim's going to talk about it, but by the time that data set came out, the device that was used in that trial was obsolete. And that's the iteration, that's the pace of how things are going. And SAPIEN 3 was commercially approved before the PARTNER 2 intermediate risk data came out. And so what we really see, this is where we stand. This is contemporary results. This is the PARTNER 2 SAPIEN 3 trial, and against surgery, there's a mortality benefit. And that mortality benefit is because separation occurs early. In this older patient population, AFib, bleeding, all these things lead to bad outcomes. Stroke, bleeding, and AFib are all bad things and lead to a late mortality after surgery. And then we continue to evolve. And our average length of stay, our median length of stay is now 2 days. We try and discharge patients on day 1. But there's still limitations, and I think we have to be upfront with patients. The long-term durability is unknown. We have 5-year data from PARTNER 1, but that's a first-generation valve. We need to continue to get more data, and we've seen it with different devices. The core valve intermediate risk, TAVR, again, shows comparable data. But with all this data, how do you incorporate it? And the guidelines really cannot keep up with the data, right? I mean, the trials are coming out, data's coming out, and so that by the time the guidelines are there, it becomes obsolete. The TAVR for 2A, for intermediate risk was given a 2A in the 2017 guidelines. It was given a 2A instead of a class 1 because there was only one randomized trial. The second randomized trial, core valve TAVR, was published 2 weeks after these guidelines came out. So, how do the guidelines iterate? And that's always a challenge as well. But what's really happened over the last decade, when we're doing TAVR a decade ago, it's like, okay, who does poorly with surgery? Let's try TAVR. The old patient, the frail patient. And we've really gone away from that conversation to who does well with TAVR, because we understand the anatomy. That 88-year-old that I showed you earlier with ideal anatomy, who can get a transfemoral awake TAVR, goes home the next day. That same patient, if they're 88, that's one thing. But if they're 78 and their anatomy is ideal, we often push TAVR. But if they're 78 and their anatomy is not ideal, meaning they have calcified femoral arteries, borderline access, the annular anatomy has a lot of calcium, then you go ahead with surgery. And I think those are the things that you have to incorporate. And there's a lot of reasons outcomes have improved. Tamim's going to go through all this stuff, but procedural technique has improved, the imaging has improved, the screening, as well as the devices. And we just have learned how to better image the aortic valve and aortic valve complex. And CT has played a huge role in that, as well as 3D echo. And I think 3D imaging is crucial to success and looking for vascular complications, but also learning who not to treat. And I think one of the things that I'm terrible at, and as physicians, as interventionalists, we generally are terrible at, is saying no. I think we all like challenges, but there are things to say no. There are patients who are anatomically not suitable for surgery, and they do well if they're robust and fit. But the patients that are demented, frail, that are bedbound, they're dying with their AS, not from their AS. So fixing it isn't going to help. And so I think learning which patients to say no is often a challenge. I think as TAVR evolves, I think we have to continue to advocate for our patients. The right calculation is going to be different in any individual patient. What an individual, and this is where the heart team and shared decision making, Megan Cohort at Dartmouth has really pushed this, really has to take into consideration. If understanding durability, discussing all the issues, that 88-year-old is appropriate, another 88-year-old may not. One 75-year-old may be, and another one may not. And I think taking the patient's values and what their goals are into consideration is key. How we do that in the regulatory environment is challenging. And, it's frustrating. I had a case of a 70-something, I think a 78-year-old gentleman who took care of his demented wife. He wanted TAVR. In that point, only high risk was improved. He didn't want randomization in the intermediate risk study because he said he can't leave his wife alone. From a regulatory standpoint, it wasn't approved, so he refused treatment. He was an ideal candidate when he came in. He came back a year later and his EF was 20%. Right? And so we're sort of being pushed to a direction sometimes where we can't provide a therapy that we know is life-saving because of regulatory hurdles. And so we sort of push and try and get around those at some point, but those are challenges. And I think as physicians, we have to continue to advocate for that. As I said, the devices have evolved. And over the last decade, there's been a new technology, a truly disruptive technology. As I said, an additional more than 30,000 patients with aortic stenosis being treated. There's improved clinical outcomes through both device iteration and refinement of procedural technique. The guidelines have changed. There have been 2 update guidelines published since TAVR got approved. And I think that's 2014 and 2017. It shows how rapidly it's evolving. And a lot of the improvement in outcomes is because of better understanding and better imaging. And there's been a good dispersion of technology. There's about 500 TAVR centers, but there's about 1,300 open heart centers. So how do you provide access to those patients that are at hospitals that have open heart but not TAVR? And how do you disperse this technology in a way where you get safe outcomes? And the heart team development. And that started with syntax and CABG versus PCI, but it's really been much advanced through structural heart. And this heart team is key. From preoperative, but also to procedural care. And in the end, there's a lot of reasons, right? We all have our goals. Physicians are going to be self-serving. Egos interfere. The interventionalist says, I can do that easily, and the surgeon's like, no, you're not going to do it well, I can do it better. Complex cases, there's not a right answer, and we argue. We have our Wednesday morning meeting, and we don't always agree. In complex cases, there's no right answer sometimes, and you don't know what the right approach should be. But also, the reason that the heart team is key is the complementary skill set is useful. Getting a surgeon's perspective who sees that anatomy directly every day changes how we approach some of these cases. And I think that's a real important thing. But there are a lot of factors that affect the heart team decision. And those of you that are going into structural, when you look for a job, the physicians on the team, it really depends who's the dominant physicians. I see some heart teams that are driven by the surgeons, others by the interventionalists. And it's not a equal footing. Depends who's more powerful in the hospital sometimes. And then they get to make the decision and they sort of impose the decision. But also team strengths and weaknesses, and we've seen that. Some hospitals are very good at PCI, some are very good at CABG. You guys have all seen that bubble plot from the syntax study of outcomes in CABG versus PCI. There are strengths and weaknesses, and that may lead to bias as to which direction to go. But also hospital politics. One of the challenges is TAVR, especially in the Midwest, the reimbursement is not great. And I think that plays a huge role in decision making. AVR is one of the best reimbursement and best profit margins for hospitals, right? So hospitals don't want to take that away and lose money on TAVR. And so for many hospitals, there was always a limit on the number of cases that could be done. So that obviously, and finances play a role. But the heart team has to evolve. And early on, it was, okay, what is the anatomy? Is it good? Is the patient appropriate? But now we have to evolve to say, is what's best for this patient? One 75-year-old may be different than another. To integrate the imaging, what is the likelihood of success with TAVR? What is it with surgery? But there are challenges. The heart team time is not reimbursed. We look at all our CTs. We have a Wednesday morning meeting for an hour and a half with our echo surgeon. And none of this time is reimbursed in the current environment. So especially depending, we're fortunate to be in a university setting where that doesn't matter. But in a setting where you're measured by your productivity, RVUs, and finances, can you spend an hour and a half looking at CTs and another hour and a half, so 3 hours a week? That's completely unreimbursed time. And who's going to support that? And that becomes a challenge as well. And before we continue to evolve TAVR, there's still a ton of unanswered questions. And I don't have time to go through all this, but these are important things, from bicuspid valves to what happens to coronary disease, does it progress, how easy to intervene after. And valve choice, we'll have a third valve probably approved next year. And involving risk as we get the low risk data next year at ACC from low risk studies. These are all going to be important. But I think it's an exciting field, and when you look at the projections, the TAVR, structural heart will be a larger percentage of the pie than coronary intervention within 10 years, right? And it's going to be important, and the people that are doing it need to understand how to do it. And there's obviously a journey to becoming a structural interventionalist. And there's a lot of ways to get training. You're all interventional fellows, so I would, if you want to do structural, I think it's important to get a dedicated structural year. Yes, you can do it without, companies do trainings, but to really understand and get the experience, there are programs that offer training and get a dedicated year. People have done these other things, apprenticeships, meetings, and courses, but I don't think that's ideal. But one thing I would say is, become an expert at coronary intervention first. You may not do a ton of coronaries if you focus on structural, but the catheter skills are invaluable and will serve you well in the future, right? You don't know when you're going to need it. I still do a lot of PCI on these TAVR patients, so I think all of that is important. But beyond the procedure, understand the disease you are treating. Part of, over the last decade, the low flow, low gradient, which we never really understood, we've gotten much better understanding. About 25 to 30% of the patients we treat are low flow, low gradient. Preserved EF, but the gradients are less than 30, but it's severe AS. Philippe Pibereau from Canada has really been instrumental in pushing it forward. And that's really in the last decade, right? I mean, should we be treating those patients or not? The disease process, is it severe AS or is it not? It's that decision-making that's difficult. And then, it's not just TAVR. There's a ton of other structural interventions. We're going to talk about mitral and left atrial appendage and other things today, pulmonic valves. Tamim does pulmonic and tricuspid with our congenital folks. Those are all important. And you can't be an expert in all of them. And focus on what you can. And it depends. Obviously, in some centers, you have to do everything because there's not enough volume and there's only one structural interventionalist. In other centers, you need to focus. You got to prioritize and create a team atmosphere, and including the fellows, the cardiologist, and everyone, so to sort of distribute the load from not only the procedure, but the clinical care of the patient. But in the end, you got to make sure you're properly trained. And that's sometimes the challenge, and different programs train people differently. But you have to feel comfortable not with the procedure itself, because I think all of you will have catheter skills, you can do the procedure, but understanding what can go wrong, understanding how to manage that. And that only comes from sheer volume, right? You just got to do a ton of cases to understand that. And to know your limits. We are obviously at Columbia, you guys have heard, I think Dimitri was down here, you've heard from Dimitri and Ajay about CTOs. I'm not going to do CTOs, right? It doesn't make sense. I know, and I will do other complex cases as it relates to my TAVR patients, but choices need to be made and sort of choose what you're going to focus on. You can't be the expert in everything, and if you try to be, people won't trust you. People won't respect you. But now you've gotten the training. How about finding a job? And that's obviously one of the most stressful things. And one of the things that in medicine we do a very poor job is training people how to find a job. And we struggle with our own fellows, and it depends on what you want, right? I mean, and there's compromise that need to be made. There's choices to be made, academic versus private, right? I mean, we're in an academic center. There's some huge advantages to that, but there are also trade-offs. Sometimes it's salary, sometimes it's quality of life, sometimes it's efficiency. There are different things, and you take trade-offs for academic versus private, but there's intellectual stimulation that comes, in my mind, more with an academic job. But these definitions are not so clear in the interventional world, right? There's a lot of great private clinics that do a ton of academic work, right? I think, was Hemel down here? Hemel Gada is one of our former fellows, is in Harrisburg, and they have a huge clinic and a program, and they participate in a lot of these studies. But also think about location versus opportunity. Oftentimes they won't end up in the same place, right? If you're willing to go to somewhere in the Midwest where there's a need, you might get a better opportunity than if you say, I have to stay in California or New York, where it's a much more crowded field. And a dedicated structural versus a mixed practice. I mean, it's hard right now to find dedicated structural jobs because a lot of the senior guys or mid-career guys, I should say, and women in their 50s are interested in doing structural because PCI volumes are down and they're trying to do more structural, right? And so they're not willing to necessarily give up. But think about, and so oftentimes the job is, well, do echoes on the side, do a stress test, do some coronaries, and do TAVR. And I think that's some of the challenges. And that's not an ideal job, but it's difficult, and you have to sort of think about that. And when you're evaluating the opportunities, think about several things. Who is in control and who is driving the process? We've had fellows look at jobs, right, where the hospital is trying to start a structural program. And they go interview, and the questions they're asked are, what do the members of that program think? So the hospital is trying to start a structural program, but it's not the surgeons trying to start it. So you have two surgeon groups, and they're not engaged. That's not going to succeed. They're absolutely going to fail. So that's not a job worth taking in my mind. And also, what is the relationship between the surgeons and the cardiologist? Who's driving the process? If there's a terrible relationship, as a junior guy or woman going into it, that's not what you want to do. As a young person, you don't want to be in the middle of a battle between the surgeons and the cardiologists. You won't win that, right? And it's only going to hurt you. So try and talk to people around, understand who's in control at the hospital, who's driving the process, and how you take next steps. Is there a heart team? Is it a forced heart team, or is it a real heart team? We get a lot of referrals from New Jersey, from physicians that are near hospitals that do TAVR. But the reason they don't send to their hospital is, so there's a heart team. It consists of one surgical group, one interventional group. But the hospital has not only one interventional group, but 3 interventional groups. So 2 other groups are not part of the heart team. They don't want to send their patients to their competition, so they send to a further hospital, right? So that's a forced heart team. And this is part of the regulatory burden. I don't know how these things change or evolve, but that's some of the challenges. And so you got to understand what is the local politics and dynamics. You're not going to get away from it, but it's important to go in with your eyes open and understand what's going on. And then, is there institutional support, right? In the end, there's a lot of unreimbursed time. If they're judging you by productivity and RVUs and you're spending 10 hours a week of unreimbursed time, who's going to compensate you for it? That has to be from the institution, or it has to be from the large group, or this large interventional cardiology group says, we need this program. Yes, you'll have this percentage free time to do this. But make sure that you have the support and that you have the support for that time before you go in. And then finally, what are the metrics for success? Is it growth of the program? Is it quality? Is it a combination of everything? But ask what you're going to be judged on, right? If what you're going to be judged on is growth of the program, but the people there aren't interested in growing the program and the surgeons aren't going to support it, then you're going to fail. So what are the metrics? Is it building a team? Is it quality? What is it? Or is it participating in studies, gaining access to trials? Those are all important things. But in the end, the keys are to start is proper training and skills, right? In the end, you can't hide your deficiencies. You need to be properly trained, have good catheter skills, have good imaging, understand the anatomy. You're going to have to work hard. You're going to have to be dedicated to the field. And I think it's going to be a lot of unreimbursed time. But in mentorship, and obviously I was lucky, I look at this picture, I feel a lot older when I look at this picture, but that's Marty Leon and my friend Matt Williams, who's my surgical colleague. We were fellows around the same time. We sort of grew up with this. Marty was our mentor and is our mentor. Matt left and he runs the program at NYU, but it really helped grow and gave opportunities. And I think as we grow, we want to do the same. But in the end, sometimes it comes down to luck. You've got to be right place, right time. The first job will likely not be your last job, right? You will likely have to move around till you find the right opportunity. And those things that I'm saying, you're going to learn on the job and things like that. But in the end, be flexible, meaning learn to compromise. You're not, right out of the gate, you're not going to get everything you want. Learn to compromise. You're going to have to make some trade-offs, whether it's time at home or whether it's the type of cases you get to do or what you get to do or who you support. Learn to compromise and say, you got to put in your time. If there's an opportunity where there's a 60-year-old, the interventionists are in their 60s, that might be a good opportunity. You bide your time and then you go into that role if you prove yourself. So learn that it's not going to come right off the bat. You got to learn to be flexible. Be nice. I know it's a simple thing, but don't stab other people in the back. Don't do other things. Don't try and take cases. Always communicate to the referrings. Communicate with your colleagues. Communicate with the nurses and the staff. I don't know how many careers have been derailed by people just not being pleasant, not being a good person, and stabbing people in the back or being mean to the staff and nurses. All that stuff comes back. You will get, people know who you are. People will evaluate you that way. And it's not just how you interact with your colleagues on the physician level, but everyone else. And you will get referrals because of the type of person you are. And don't forget that. But in the end, be a good doctor. You need to treat the right patient. And sometimes being a good doctor is saying no and communicating that to the family. Our longest consultations in clinic that are usually an hour are the patients that we don't treat. Convincing the family why it's not appropriate, talking to the referring, but in the end, that's being a good doctor, and you need to do that. And be honest with yourself what you want. And even as I progress through my stages of career, I have to be honest with myself what I want, right? I don't want to necessarily run a cath lab. I need to figure out what I want to do. And what are your goals? Is this your dream and this is what you want to do? Or do you have goals outside of medicine and say, okay, I'm going to make compromises because I want to pursue my other hobbies, and be honest with yourself up front about that. And then finally, be open when opportunities arise. There's never a perfect opportunity. There's never a perfect time. And I think that's something to keep in mind. But sometimes you're there and you didn't realize there was going to be an opportunity, and there is. And my own, and some, I'm not working harder than anyone else. I'm not smarter than anyone else. And I just got lucky at the right place, right time, right? I was at UCSF as a cardiology fellow. I didn't get along with our chief of cardiology. He believed strongly everyone should do basic science research. I wasn't interested. So I decided to leave California. I'd done all of my training in California. My wife is born and raised there. We decided to go to New York for a year. I interviewed at Lenox Hill with Marty Leon and Jeff Moses. I didn't get a spot in their fellowship. I decided just to come. My wife said New York or Chicago, so I took a spot at Columbia for a year, right? Planned to go back. 1 month after I accepted the fellowship, it was Marty announced they were moving, so I started the fellowship in July 1, and the group came in August. Marty, Leon, Jeff Moses, the whole group from CRF. So it was, but I was the only fellow. I worked hard, right? And that was an opportunity. So, and my wife was supported. I worked from 7 to 11 because there was only one fellow. I did all of Jeff's cases, and back and forth, 10 cases a day with him, 11 cases. But because that opportunity came, and I was interested in structural. I always wanted to do structural, and then I was looking for a job, and Marty's like, are you interested in staying on? We're starting TAVR. But it was because my eyes were open, and the opportunity was there, and I was able to take advantage that it worked out. And in the end, if you're happy with what you do, sometimes things will work out. And I always show this email that I had. This is from March 2nd of 2003. I was a cardiology fellow, and I was working with my mentor, Rick Shunk, at the VA. I was interested in structural, and I sent him an idea for a research project. I wanted to look at embolic protection during valvuloplasty. And I wrote in here, I think this issue will become more important, especially if percutaneous valves become a reality in the future. And I said I wanted to work on developing a filter, and I think there are opportunities to do so. That was in 2003, and I was always interested in structural, and it worked out. I got lucky, right? I got an opportunity to be co-PI of the Sentinel trial. But, sometimes it doesn't. And I think if you can, just continue to do what you're interested in doing, and sometimes it'll work out, but you just got to make sure you're happy with what you're doing. Thank you very much.